Hello, this is Oleg, Borisenko and Market Access Insider channel. In our programs we discuss organization and financing of healthcare services and medical technologies in European countries. Today we're in Berlin, Germany, and we're going to talk to Dr. Wilm Quentin from Institute of Technology and Management in Berlin. He's one of the best experts in German and European healthcare systems. We're going to cover a broad range of topics, including organization and financing of hospital and ambulatory services, statutory and private health insurance, the DRG system and EBM catalog, and the future of GBA Innovation Fund. Hope you will enjoy the program. Quentin, thanks for joining us on this program.
Yeah, good morning. Hi.
Can we start with a general overview of the German healthcare system?
Sure. The German healthcare system, in 2 minutes or in a box, It's probably, the first thing one should know is that it's the oldest social health insurance system in the world. So it was established by Bismarck in the 19th century. And many things also even today, can be explained by the history of how the German healthcare system developed. And so basically it's a social health insurance system, but there's also still a prominent private health insurance system which work next to each other. And there's a strong process of self-regulation in the system, so it's not really steered. Most of the regulation in the system doesn't come from the government. The overall framework comes from the government, but many of the details of decision-making are really negotiated between the main actors, which are the association of sickness funds and the associations of the providers, so the associations of hospitals and the associations of ambulatory sickness fund physicians. Whereas the private health insurance system, it really operates more or less independently and with much less regulation. And then the other thing that is important is that Germany is a federal country, so basically the framework legislation, mostly for the health insurance, is established at the national level, but many of the other things like the hospital planning and the implementation oversight happens at the Länder level, at the state level. So it's really a complex system with the self-regulatory powers, the federal government and the Länder government, which makes the German healthcare system quite complex. I would say one of the most complex in the world. Although I think everybody would always say their healthcare system is complex.
Oh, right. And who are the main players in the system?
The main players are really, it starts with the Federal Ministry of Health. Then there's the Federal Joint Committee, which is the main representation of the self-regulatory powers, so the Association of Sickness Funds, the Association of Hospitals, and the Association of Physicians. And then there are also representatives from patients in the Federal Joint Committee, but they don't have a voting power. So the main decisions are really taken by the payers and providers.
All right, and then again, it also reflects the self-regulation, feature of the system, which is
exactly
quite relatively unique in Europe.
Usually, the way laws are passed in Germany is that the government or parliament passes the law, and it says, we want to achieve this objective, and the details will be specified by the self-regulatory powers, which means then usually the Federal Joint Committee.
All right.
And the Federal Joint Committee, also one unusual feature probably for many countries, is that they don't pass laws, but they pass ordinances. So they have a legal character. The things that they decide really are then law in Germany.
Mm-hmm. All right. And what's the contribution of the private health insurance versus statutory health insurance?
It's statutory health insurance. It covers about 90% of the population, and private health insurance covers about 10% of the population. So for the biggest part of the population, really the statutory health insurance is the most important player in the system, but the private health insurance is not negligible, and in particular for certain physicians working in ambulatory care, a substantial part of their income comes from private health insurance.
Mm-hmm. Is there any difference in coverage of services between private and statutory health insurances?
Yeah, for statutory health insurance, coverage is regulated. There is a minimum benefits package, which is the same across all statutory health insurers, and then the individual funds can add on certain services or certain technologies or like certain benefits that are valued by patients, whereas in the private health insurance it really depends on the individual contract. Some have very generous contracts where basically everything is covered. Others can have much more restricted coverage where you have to first make high deductibles before coverage kicks in. And then also with regard to technologies and services that are covered, it can be much more restricted than in the social health insurance, in fact.
All right, excellent. Can we now move to finance in our healthcare system? Could you just again briefly describe compartments of financing, and then we can move to the DRG system more specifically?
I mean, for the financing first, the revenue generation really comes mostly from income-related contributions in Germany, at least for the social health insurance. Everybody pays about 15% of their income for the social health insurance, and about half of that is financed by the employers, and the other half is financed by the employees. Then the individual sickness funds can have small additional premiums, which are again income-related. And these, so basically there's competition around these small additional premiums. And then for the private health insurance, it's per capita premiums that depend on your age, on your health status, and an interesting feature maybe also with regard to private health insurance is that for civil servants, most of the people who are insured with private health insurance are in fact civil servants, and part of their healthcare cost is really covered by the government, and therefore their contributions to the private health insurance are relatively low compared to the coverage that they get. Then on the expenditure side, so basically then there's a system of redistribution within the healthcare system, and it's the German Health Fund which redistributes the money and then reallocates it to the sickness funds depending on the risk structure of the insured in the sickness funds. And then much of the financing of providers really depends on collective contracts between all sickness funds and all physicians, or all sickness funds and all hospitals. And the framework for this financing is determined by the federal government. So basically the hospital payment system is determined by federal regulation, but then the rate of payment depends on negotiations at the state level, and the same is true also for the payment system in ambulatory care, that basically the framework is determined at the federal level by law, then much of the total volume is determined by federal negotiations between sickness funds and physicians, and then the specific point value of how much worth a service is at the individual patient level depends on negotiations at the state level, but also sometimes it depends on the individual practice.
All right. And another question, so how common is copayment in German system?
Copayments Copayments are the rule for pharmaceuticals. So for prescriptions in outpatient care, people have to make a copayment between 5 and 10 euros usually. A minimum of 5, a maximum of 10, and in between it's 10% of the price of the prescription. For physician practice visits, there used to be a copayment for about 10 years between, I think it was 2005 and 2015, until it was abolished again. For hospital, there's a copayment of 10 euros per day. And in private health insurance, so that's all for sickness funds. In private health insurance, the copayment depends on the individual contracts, and sometimes there's even co-insurance where you have to cover 10% of the costs or 20% of the costs in addition to deductibles. There are no deductibles in social health insurance. There is for pharmaceuticals also there is a system of reference prices. That means that if the drugs that you want to take are more expensive than what the average drug in that group of drugs would cost, then you have to cover the difference. So, for example, if you are prescribed a generic drug but you want to take the brand drug, then you have to cover the difference of the price between the generic and the brand drug. And similar systems exist also for medical devices, like for crutches or for or orthopedic shoes and things like that. There's a reference price list determined by the sickness funds. But if you want something that is more expensive, then you have to cover the difference between the price, the basic price that is covered, and the more expensive price that you have chosen.
All right. Can we now move to the hospital financing? Could you again just make a brief overview of the DRG system in Germany?
Yeah, the DRG system. I mean, the DRG system was introduced in Germany in 2003. So it was it was a bit later than in many other countries in Europe where it started already in the 1990s, but then was introduced very completely for all hospitals in Germany. It was originally imported from Australia, the DRG system, and then it was later adapted and adjusted to the German context based on German cost data. I think some particularities of the German DRG system are that it's really based on detailed analysis of cost data from hospitals. So the costing system that was implemented together with the DRG system is really very detailed and allows patient-level cost information about patients treated in a sample of about 10% of German hospitals. And this allows refinement, very detailed refinement of the DRG system. The payment system then depends on the one hand on the DRG that the patients are classified into, and on the other hand on the base rate that is determined by negotiations between sickness funds and the National Association of Hospitals, or the Federal Association of Hospitals.
All right. And how the process of update of the DRG system works?
So the process of updates of the DRG system works that there's an institute for the hospital payment system in Germany, and they collect all the data from the hospitals and then analyze the data in order to see, on the one hand, whether the DRGs are homogeneous, so whether all the patients within each individual DRG are sufficiently similar in order to be able to group them together for payment purposes. And if they find that there are some groups of patients or certain technologies that do not fit in the existing DRGs, then they may exclude them and try to reassign them to other DRGs. Or they may split the DRGs, finding that, for example, certain complications are more important than they thought in the past, and so they will split the existing DRGs. Or they may even create new DRGs if they find that these new technologies are so important and there is a sufficiently large number of patients to warrant creating a new DRG, then they may create a new DRG.
Is there any threshold for how many cases should be reported in order to justify a new DRG?
There's no hard threshold. I mean, there are at least at the beginning, the Institute for the Hospital Payment System published something that if it's at least 30 cases within their data, which is 10% of the hospital sample, then they may consider introducing a new DRG. But in fact, it's always evaluated in view of the total effect on the hospital payment system, whether it's worth introducing a new DRG or not.
All right. So is it possible to make a suggestion to INEC for creation, or do they really develop this system on their own?
On the one hand, they do the analysis themselves, but on the other hand, they run a system of structured dialogue. And I think that's also something that is very specific for the German DRG system, that on the one hand, they have good data. On the other hand, they have the system of a structured dialogue with the partners of the self-regulation, which means that hospitals and medical professional associations have the possibility to make suggestions to the INEC about how to improve the hospital payment system if they think that it doesn't adequately reflect their practices. And then on the one hand, so the process really is if there is a new technology that is introduced in Germany, then on the one hand it needs to receive a code, a medical procedure code, in order to be reflected in the DRG system, because the data collection always depends on the coding of medical diagnosis and procedures, and only then can the INEC find that this procedure is more expensive in the data than if the procedure doesn't have a procedure code. And this code is assigned to a new procedure from the DIMD, which is the German Institute of Medical Documentation and Informatics. So this is one pathway, and then on the other hand, the hospitals, so the hospitals and physicians make suggestions to the German Institute of Medical Documentation and Information, and then they also make suggestions to the INEC to look into the data that they have and to see whether this technology is adequately reflected.
All right. So another question on, because German DRG system also has add-on reimbursement component, so in order to create ZE, is it required to have positive NUB in the past for these technologies, or it's not really a prerequisite?
Yeah, that's an important term that you mentioned, the NUB, which means Neue Untersuchungs- und Behandlungsmethoden, so basically new diagnostic and treatment procedure or methods. And in order to be recognized as an NUB, a hospital has to apply to the INEC, and then Then it evaluates all the applications that it receives during a year, and it will assign different statuses to the technologies that it receives. And NUB status 1 means that it has positively evaluated the technology and that it may consider introducing an add-on payment for the hospitals for these technologies. And there are different types of add-on payments. There are add-on payments where INEC calculates the average costs of this technology, and so there's a fixed price for this, basically a fee-for-service price for the new technology. There are other technologies where INEC says, oh, it seems the technology is sold at very different prices to different hospitals, and we are not sure yet what price should be assigned. So basically there is this technology and it can be done in hospitals, but hospitals will need to negotiate with sickness funds about the price for this technology. And then once it has received NUB status 1, INEC will automatically evaluate for the next DRG version that it will calculate and develop, and whether this can be integrated into the existing system, either by increasing the relative weight of a DRG or by splitting DRGs, by creating new ones, as I mentioned before. Yeah.
So if technology has a NUB status 1, that more or less it's already on the right track to be integrated, right, into the system.
Yeah. And there are different levels of integration. So basically NUB status 1 is the first step in being integrated. Then there's not only to create new DRGs and to really integrate it into the system, but there's the intermediate system of the supplementary fees in the German DRG system. And these supplementary fees are one mechanism that the INEC uses to kind of increase homogeneity of the DRGs itself by excluding certain things that would decrease homogeneity, either because usually because they are blood products or pharmaceuticals or technologies that are provided to patients which are classified into different DRGs, but not to all those patients in the DRG. So by excluding these things from the DRG becomes more homogeneous, and it is possible to reimburse those services separately. And so basically often new technologies, first they are assigned NUB status, then they become supplementary fees, and then maybe if all the patients who have in the past received a different procedure will now receive the new procedure, then it's really integrated into the DRG system by making this part of the DRG.
All right. So NUB in theory could cover also diagnostic tests, right, or diagnostic technologies, but in practice we don't see that. So are there any restrictions of what could be covered within NUB?
It's relatively broad, really, what could be covered. The most important criterion is that it's expensive and it's not adequately reimbursed by the DRG system. And this brings me to a particularity also in general about the hospital reimbursement system, because in fact hospitals can use any technology that they want in Germany. So the regulation of the use of technologies in the German healthcare system is differently for the inpatient sector and for the ambulatory sector. In the inpatient sector, hospitals are basically free to use any new technology that they have. They just won't be reimbursed for using it, because the idea is that the current payment system should cover the costs of hospital care, but if there's a new technology that maybe improves diagnostic accuracy and therefore also enables hospitals to discharge patients earlier, then maybe the hospitals have an incentive to introduce this new diagnostic and to kind of compensate by having lower costs for other services during the inpatient stay. But if it's really so expensive and doesn't lead to cost reductions in other areas of care, then there's a case for the hospital to apply to the INEC in order to receive an add-on payment for the reimbursement. So not all new technologies that are introduced into the hospital system in Germany need to receive an NUB. It's only those technologies that are too expensive to be reimbursed through the normal hospital payment system.
All right. So you also mentioned potentially some evidence-related questions for novel technologies. So in 2016, GBA started early benefit assessment process in connection to NUB. Could you elaborate on the progress and the status of these assessments so far?
I mean, the early benefits assessment of the GBA really relates to the reimbursement of technologies in the to the reimbursement of pharmaceuticals in the ambulatory sector. So the GBA is really So basically, these are two separate systems. The GBA is the main decision-making body, but for the hospital payment system, it's really the INEC and directly the statutory health insurers and the private health insurers, which negotiate together with the hospital federation. So they own the INEC and make the decisions about the hospital payment system. For the GBA and the early benefits assessment, that relates to the ambulatory sector and to the reimbursement of new pharmaceuticals. And the GBA has its own institute, which is the IQWiC, the Institute for Quality and Economics in the Healthcare System. And the IQWiC makes recommendations to the GBA based on its benefits assessment. And the early benefits assessment is really done by the IQWiC based on dossiers, based on documentation submitted by the producers of the technologies to the IQWiC. And then they make the decision whether there is an additional benefit, an additional value of the new technology. And only if they find additional value, then the GBA may decide that sickness funds should negotiate with producers about the price for the new technology. Whereas if the IQWiC finds that there is no additional value of the new technology, then the new pharmaceutical will be automatically assigned to a reference group of drugs, and then basically the reference price will apply that is already applied to other similar pharmaceutical products.
All right. We also know that GBA also issues some ordinances in relation to some of the coverage of technologies in hospital sector, potentially that GBA could exclude them from coverage within state health insurance. Could you briefly elaborate on that practice?
Basically, I mean, the idea is, in general, everything is allowed in the inpatient sector, but only if it's explicitly excluded, then it's not allowed. It's the inverse of what is done in the ambulatory sector, where everything is not allowed except it's explicitly allowed by the GBA. And the process of excluding new technologies, it happens relatively rarely, really. Much more important is the process of incorporating new technologies into the hospital system and into the DRG system. So the idea of excluding technologies is only if it's really proven that it's not effective and that it really rather harms patients, then the GBA will decide to exclude those technologies from use in the inpatient sector. But in general, I would say it doesn't really happen often because, I mean, first hospitals and physicians need to use the technologies and to, for some reason, think that it is better. And so the probability that like all the physicians, the medical associations decide to use a technology that doesn't have additional value and is and nevertheless is more expensive is relatively rare.